the same, the ERPR using HNE, and we had published this in JPath Inform. It had a very good accuracy of over 85%, and as we say, an AUC of more than 85% in artificial intelligence is as close to as human ones, because mining the human error. So like Dr. Somesh said, that acceptance is not there. So this was one of the paper. On HNE, we did a BRAF mutation in thyroid with a very good accuracy, but still it has not been implemented for the masses because that acceptance is still not had come. We have started this doing in our setup. Again, similar paper we did on EGFR mutations using HNE. Again, real-time diagnosis on the EGFR using a HNE slide. Otherwise, a PCR will require, say, 7 days for the report. Similarly, a deep learn, this was a paper done by my colleague Abhishek with myself and Rajiv in that, where using the HNE images, we could predict that this patient will have a brain mets using us in future in a non-small cell lung cancer. And this was well accepted, and it had a good prognosis and a good acceptance. This I had presented last year at the ACDP Budapest, where an HNE image, we were predicting whether this had an HPV positive or HPV negative, because human papilloma virus in head and neck has a prognostic significance. And if you see, it had almost a good sensitivity and specificity of almost of 95%. And it was compared with the gold standard, that is in situ hybridization. And we had a good concordance of 0.95%. Now, many slides have a lot of artifacts. So this is a validation, this is a quality control algorithm which we have developed in our center at Tata Memorial Hospital, which will tell you that this slide should not be submitted to the pathologist. Again, a lymph node metastasis, this I presented last year about predicting lymph node. Pan cancer, if you see the different specialties, thoracic, breast, GI, urology, and with a good positive predictive value of 0.95 and a recall of 0.86, that if I throw the same slide maybe after 2 months to the model, it has a good accuracy in identifying. So these are multiple things which we are doing across the pan. Lymph node metastasis, the AI is the model which we developed is actually highlighting. If you see, there's a very small tumor sitting here. The AI in its heat map is identifying. It is like an assist to me that, okay, there's a MET, see it properly. The small MET, the AI model is picking up, quantifying it, how big it is. Again, with a good predictive value. So that's all we have doing in our lab. So now, as I said, like I started on the first slide, I reach again to this last slide, that right now, we heard a lot of things that the AI is going to kill jobs, or it's a terror or something. It's an assisted tool. It will always assist you in what you are doing. And AI has been built by the data which you have provided. AI is not generating any data on its own. So it will always, it is the ground truth always lies with the doctors or the person who has given the data. So right now we are at this level, and we have to embrace and accept this. Otherwise, it's our loss and we will perish. So this was what we do in our lab at TMH with my team here, and with collaboration with DBT, Niti Aayog, and IIT Bombay is a close collaborator for us. So this was the crux with all the work which we are doing in TMH Mumbai.
So thanks a lot, Dr. Yadav. It's actually now a little hard to imagine that how you would function without AI, or how you were functioning without AI. So it appears that a lot of work is being done along with the tech by you. So before I ask the audience for a question, I want to ask you something that, I mean, how did you approach the technology? Did you get trained in them, in any of them formally, or you learned on the job?
So it was learning on the fly. So it was learning on the job. So the first AI model which I started working on was in 2018. We got the ERPR HER2 model, which was commercially developed by Visiopharm, and we started using it. So it took us at least 2 years initially to accept that, okay, it is matching with what we are giving the results. And now we use the model, we sign the reports, but it becomes a double check, because if you know the HER2 guidelines, a 10% is positive, complete membranous staining is positive. So an AI model helps me, okay, what this is highlighting is 10% as 3+. I can cross-check with under my microscope or now a digital slide. So yes, it did take time, and those were the commercially available. Now in my own computational lab, we are developing our own models. So the models which I showed you are the one which are in-house developed with the collaboration with IIT Bombay, and we have a team, computational biologists and scientists with us. So it did take time, but yes, we have to accept it.
So great. It seems you approached it with positivity, embraced it, and now you are on to the creating part of it. That's a fantastic journey, I must say. From the audience, are there any questions to be asked from Dr. Subhash? So what we'll do is we'll break the trend, and instead of going to Group Captain Naheem, who also is into some kind of a visual diagnostics, if I may use the term. So let's speak to, or let's ask a core clinician, Colonel Shaw, as to how his field has changed and how has he perceiving this change over a period of time.
Thank you, sir. Thank you for the opportunity to come here and talk about this. There's a lot of changes happening in clinical fields. I'm a hardcore clinician, and I don't deal with any new, starting of AI models or something. We just use the applications that are there. So I'm a neonatologist, and in neonatology, the main AI inroads is on predictions. Like we have some serious conditions like neonatal sepsis in very preterm babies, or bronchopulmonary dysplasia, which is a chronic lung condition, and it actually is a very costly and also little, life-endangering kind of condition. And then some dreaded conditions like retinopathy of prematurity. So in all these, AI has come. So there are perfect, models are there, prediction models like on the heart rate characteristics you can model, and with an algorithm you can predict whether sepsis is going to come or not. And it is evidence based, like the RCT has come on this, that HERO score or HRC score, also heart rate characteristics score. If you use that algorithm and detect and treat sepsis, the mortality can be reduced by 40%. Now these are evidence based. These are not that somebody came up with this application and we are using. We're at that stage that it has been validated. That's what I mean. Then there are BPD calculators, because these days very small preterm babies are being saved. Even in our setting in Army Hospital R&R, we are saving 600 grammer babies, 24 weekers. So they have very high risk of BPD. So there are again models exist, and you can predict whether these babies are going to have BPD or not. The problem is on this is that they will be predicting sepsis will be there or not, BPD will be there or not, but they will not be suggesting the treatment for it. What I mean is that they will be predicting sepsis is sepsis there or not, but they will not tell which antibiotics to give or whether to give antibiotics or not. There the clinical acumen comes and your expertise comes. So that is about the therapeutic part. Also in precision medicine, there's a lot of these genomics and proteomics, they have come, and the way the cancer patients are being treated, depending on their, the risk factors of their genomics and proteomics, and very, precise medicine, or like in the first lecture today, what was told that whether they will be going for transplant or they'll be going for chemotherapy, that kind of decisions are being taken. So these are all about prediction, and also sometimes some very conditions which are difficult to diagnose, like neonatal seizures. So the clinical, suspicion of a seizure may not be actually accurate. There also the algorithm has come, and the AI model can predict better, occurrence of neonatal seizure, which is almost equivalent to what a neurologist would say. So those kind of things have come in neonatology and pediatrics. And these are in use already, sir. And we, even in our setup also, we are using them. I think to shorten the time, I'll stop here.
Yeah, so thanks a lot for those inputs. So when a resident approaches you or joins your department in first year, how does he view these technologies? Is he alarmed? Is he enthused? Is he confused?
Well, I think enough discussion has happened today about whether it is. I think we should not see it as a conflict. We should see it as a help. All these tools are actually helping us in taking better decisions. So it is not about who is better. It's all are important. It's probably hybrid intelligence or mixed intelligence or human in the loop AI. That is what is the future and should be the future. Why should we fear about it? So the residents also, when we were residents, we had no knowledge about it. And we have suffered. We have seen babies dying left, right, and center for sepsis, cancer patients. But today the survival is much better. And there's a lot of role of AI there. So for the residents, I would say that embrace them, learn about them, and apply them as much as you can, as much as your understanding goes. But if you ask me what to be done futuristically from an UG perspective, the time has come probably that they should be exposed about what is AI, the statistical models, the algorithmic models, and at least start the beginning at UG level. And because they also have to, all stakeholders are important here. The person who is making the software guys are important, but then this data that we'll be giving, the clinicians will be giving. So if we don't give correct data and keep on giving data, these will not be as accurate as we feel. So there's a lot of role from clinician side as well.
So any questions or inputs from the audience to Colonel Shaw? Yes.
I'm a physician, so I just wanted to see how it can help us. You talked about predictive models in neonatal seizures. So I just want to see, like, if as in adult medicine, if we have to use a similar template. So what data we need to feed in the machine? It's because it will all depend on, if you're not correctly putting the clinical findings or data, then it can misinterpret it. So just your thought on that.
Actually, you know what? In adult medicine, the inroads of AI is much more than in pediatrics.
Yeah.
The pediatrics and neonatology has actually been much behind other fields. In fact, in cardiology and even in neurology, as you were telling, like for acute strokes, the diagnosis of strokes and prognosis of strokes, there are plenty of literature there, and many of them are evidence-based actually. The percentage of success of picking up a stroke or picking up a seizure is far more if you go through AI. And of course, the hybrid is the best. I mean, if the clinician is also there. For the nitty-gritties, maybe I'll be sharing you details in that. There are many, in Google also, like I think AlphaFold and Google Mind, those kind of things are there, which are really like voluminous data and literature is there as to how to best use of AI. We may share later on.
So these apps are there which tell you like what data you need to feed in it.
Yes, they are there. They are not only that, it has already been studied. The evidence is also there. I can share you the literature also, the RCT and whatever has happened so far.
Okay.
Thank you. So insofar as till now, what I think we understand is that understanding technology is important so as to ensure that it percolates far and wide. Second, we all need to learn on the job, and all the more reason that we become conversant with technology. And of course, we need to replace cynicism with hope, and with of course some human on the loop kind of a system. So all that probably points out that we need to expose our students to technology very early in their learning cycles. Like we have an early clinical exposure. I want to say that it's probably time to look at early technological exposure also, ETE, for the UG students, and with Dr. Praveen Iyer in the audience. And I think, so this is one idea we would want to discuss with you further. We have all been your students on how to become teachers, So ETE probably is something which we can take as a deliverable insofar we have discussed about it. And yes.
So the biggest cultural shock comes in pathology. Like we all have imagined pathologists using a microscope, and now when we see our residents, the question is like, do we give away with the microscope? Because now they are reporting on a screen. So they come up with this image that like, well, I'll have to buy a microscope, use a microscope, and we as consultants who have been, we ourselves have learned on microscope, but now we are using the screens. So that is one. And regarding about the data, be it any field, be it medicine, radiology, if you have a specific question, the question has to have a specific data for that. If your model is a diagnostic model, you don't need the additional things, maybe the whatever other things is. It is because AI model is based on pattern recognition. What we couldn't see, AI has some tools, maybe ResNet 50, a uni, it's a black box, it comes up with the data, a mathematical solution. But if you want to make a prediction, yes, then your cohort has to be uniform. The drugs which you have in terms of cancer, what chemotherapy they have taken, what age, match, everything has to be matched. For prediction, the data has to be uniform, irrespective of the field, radiology, medicine, pathology, it doesn't matter.
Yeah. So I would want to ask now